Good evening to all the aspirants present here and the doctor. We shall start the class right now. Doctor, you may share your screen too and let's start the class. So today class is on neurology and the focus key areas are dementias and acute, subacute confusional states delirium. And the speaker we have here is Dr. Shadanandan Dey, who is the senior consultant, neurologist, and stroke specialist at Apollo Multispeciality Hospital, Kolkata. So, more of the students will be joining us soon. Thank you. You may start the class.
Good evening, everybody. I'm I myself, Dr. Shadanandan Dey. I'm a consultant neurologist and a stroke specialist at Apollo Multi-Speciality Hospital. Today, in this teaching class, we will discuss about dementia and delirium, which is also known as like acute confusional state. So, if you see about dementia, it's a major neurocognitive disorder with an acquired deficit in cognitive functioning, and about 47 million people live with dementia globally. So this is a huge burden of dementia, and as life expectancy is increasing, we get more and more elderly, so you are getting more and more dementia. And all dementia share common molecular mechanism responsible for disease etiology and progression, such as hypoxia and oxidative stress, sorry, neuroinflammation, mitochondrial bioenergetics, neurodegeneration, and blood-brain barrier permeability. And definitely, advancing age is the strongest risk factor for dementia. So dementia also can cause other illnesses, can affect sleep, activities of daily living, as well as social relationship. And if you go by the data, by 2050, around 131 million people are estimated to be afflicted with dementia. So in coming years, we are going to get more and more dementia patients. So how we define dementia? Dementia is a syndrome manifested by several cognitive deficits that include memory impairment involving at least one of the following, like aphasia, maybe language disturbance. Agnosia means inability to carry out motor activity despite intact motor function, means your motor power is normal, but when you are asked to do a motor activity, you are unable to do. So that we call agnosia. Apraxia is another important feature of dementia, which is failure to recognize or identify objects despite intact sensory functions. So you have intact sensation, which is required to identify, but still you are unable to do the same. And it interferes with social, occupational, or interpersonal skills. So what are the additional features? It associated with emotional lability, impairment of intellect, mood changes, personality changes, judgment and social behavior changes, thought abnormalities, associated urine and fecal incontinence, disorientation, which may be geographical or in other perspective, and other neurological signs also. So if you see the major, hello,
Sir, can you show once again last two slides? Just missed. Gaming duty
so
and
you can see now.
level cognitive deficit. Okay.
Okay. So these are the additional feature which may happen, which you may get in like dementia. And this is the simple mnemonic actually with the name of dementia. At least you can remember a few of the causes, like D for drugs, delirium, E for emotions like depression and endocrine disorders, M for metabolic disturbance like hyperglycemia, hypoglycemia, hypercalcemia, hypomagnesemia, hypermagnesemia, like that. Eye and ear impairment means severe sensory neural deafness. Sometimes also can give rise to delirium because they are unable to hear. Sometimes because of severe vision impairment also can lead to hallucination and delusion also. Nutritional disorders means like deficiency of like vitamin B12, thiamine can lead to dementia. It similarly like sometimes in or endocrine disorder because of hypothyroidism also you can get the same. T, if you can remember for tumor, toxicity, trauma to head. And I, you can remember for infectious disorders. Some any infection in brain can lead to dementia. A, you can remember for alcohol and arteriosclerotic diseases. So these are the common mnemonic. Apart from that, there are so many causes, but to just make it simple, you can remember dementia, and by just remembering dementia, you can at least count few of the causes. So these are like possible other etiologies of dementia. Like major is like degenerative dementias, like commonest is Alzheimer's disease, followed by frontotemporal dementia, Parkinson's disease dementia, and Lewy body dementia. These are the major four degenerative dementias. Miscellaneous, like you can get dementia in Huntington disease, Wilson's disease also. Psychiatry, like you can get pseudo dementia of depression. In case of severe depression, like you can get features of dementia also. And even in schizophrenic patients, cognitive decline may occur in late life, like long standing schizophrenia patient can show features of dementia. Physiological is like a normal pressure hydrocephalus, that is a three triad of normal pressure hydrocephalus, and among them like apart from like gait and urinary incontinence, dementia or cognitive impairment is another feature. Metabolic, like with vitamin deficiency like B12, folate, hypothyroidism, chronic metabolic disturbance already we discussed. So like uremia are the other causes. T, like prime, you can remember by tumor, like it may be primary tumor, it may be metastatic also. So any tumor in the body which have metastasis in brain can lead to dementia or dementia-like feature. Traumatic, like post-traumatic dementia, subdural hematoma is another important cause. Infectious are like Prions disease. Sometimes you can get it in Prions disease, rapidly progressive dementia. Acquired immunodeficiency syndrome, like in AIDS you can get it. Syphilis now rare, but it was earlier a very common cause of infectious disease related dementia. Apart from that, cardiac vascular anorexia, like any stroke, infarction, hemodynamic insufficiency like hypoperfusion or hypoxic brain injury, you can get. In demyelinating disorder, multiple sclerosis also, later stage you can get memory impairment. Drug and toxin like alcohol, radiation exposure, like for medication also, like sometimes anticholinergic are very common cause to cause dementia, and carbon monoxide inhalation sometimes can lead to dementia like features. So how we diagnose? So uh, according to ICD-10, the evidence of decline in both memory and thinking, which is sufficient enough to impair personal activities of daily living, and memory impairment typically affect the registration, storage, and retrieval of new information like recent memory, but previously learned material like remote memory may also be lost. But many a times we see initially to start with a recent memory, and later on, as dementia advances, we may get problem with the late memory also. Thinking is also impairment, flow of idea is reduced, and the reasoning capacity impaired. Presence of clear consciousness is not there, and should be duration should be at least 6 months. So that is an important thing. Like whatever feature you get, at least you should be a considerable duration, at least for 6 months. So you can also divide dementia into two other parts, like whether it is a cortical dementia as per physiological classification, like structure involved, like cortical dementia and subcortical dementia. So in cortical dementia, usually cortex is involved, while in subcortical dementia, subcortical gray matter like thalamus, basal ganglia, brainstem are involved. So the example of cortical dementia is classical Alzheimer's disease, Pick's disease, while in subcortical dementia, you will get in Huntington's disease and Parkinson's disease dementia are mostly subcortical dementia. Usually cortical dementia are more severe, while subcortical dementia are mild to moderate. Usually motor system usually normal in cortical dementia, while in subcortical dementia, like if you have a thalamic stroke or basal ganglia stroke which is causing subcortical dementia, uh, you might get impairment of motor power also. It may be associated with sometimes flexed or extended posture. It may be associated with tremor. It may be associated with coliform movement also. Other feature which differentiate is depression is usually in cortical dementia is not very common, but there is a severe aphasia, amnesia, or agnosia may be present. While in subcortical dementia, you get delusion more frequently, and depression you get frequently, but mania is relatively rare. So this is the initial evaluation of a patient presenting with, like, if a patient comes to you and telling that I am forgetting things. So first thing is first you have to remember that age related decline in cognitive function and depressive symptoms also a common cause, but that usually occurs in later life of life. And because of the like good food and healthy lifestyle, some now we are getting age related thing in 80s. So now even with 80 years and ever, people are functioning well. So first you have to with history, family's culture, and obviously literacy is very important. So how uh, literate is a man. So dementia features may not be same for an illiterate patient and a patient who is highly educated like a professor. So in perspective of occupation, in perspective of literacy, you have to judge. So, like if a patient comes to you complaints of cognitive decline, then first you have to find out whether there is actual decline or not. If it is a normal cognitive decline, cognitive functioning in examination, then it's a normal aging, nothing to do. But if you think like yes, there is an impairment in cognitive functioning, then you have to ask whether there is an impairment in activities of daily life or not. If no impairment in activities of daily life, then again it may be a mild cognitive impairment, or it may be because of the aging, or sometimes also underlying depression can cause these features. But if there is an impairment in activities of daily life, then yes, you have to consider it dementia. Now these are some reversible causes of dementia, which you definitely, whenever you are working for a dementia patient, want to do workup for dementia patient, you have to rule out some reversible causes. So what you have to test, you have to rule out any thyroid disorder, particularly hypothyroidism, whether the patient had vitamin B12 and thiamine deficiency or not, whether this patient had chronic diseases like chronic kidney disease or chronic hepatic failure or underlying malignancy or not, whether the patient has chronic GI problem or not, like Crohn's disease. And sometimes you have to rule out whether there is a structural brain lesion or not, like it is like whether it is a normal pressure hydrocephalus, tumor, or subdural, because these are mostly treatable. Infectious disease also is are mostly treatable. So you have to find out always when you are treating, apart from degenerative causes of dementia, find out whether there is any treatable cause of dementia or not. And then depending on that, when you diagnose dementia, you have to do tests and imaging. So we are coming later what we have to do. So now whenever you are declaring a patient like patient has dementia, you have to definitely rule out delirium, because sometimes features are like very common. So and we will talk more about delirium in later part of our talk, but how you differentiate, that is also very important. So usually evidence is usually available from the history, examination, investigate, and that delirium is a direct, usually a consequence of a general medical condition. Like if a patient has substance abuse, a patient is taking drugs, like then sudden withdrawal sometimes lead to dementia like feature. Sometimes also alcohol withdrawal we commonly see causes delirium like feature. And so whether in this patient whether they have pre-existing dementia or not, that is also important. So sometimes it happens like uh, delirium is superimposed on dementia. So you have to find out whether there was some cognitive decline at least lasting for more than 6 months or not. Then only you can tell that yes, this is delirium superimposed on dementia. So sometimes you don't get history. Sometimes even with history you are not able to tell whether a patient has delirium or dementia or delirium superimposed on dementia. Then always treat delirium first, then you can always later on when the patient improves decide whether there was an underlying dementia or not. So how to differentiate? Usually in delirium onset is very abrupt, like in the evening patient was talking well, You examined, like patient was doing well, there was no problem, and suddenly he become violent, delirious, like he become agitated, and sometimes hallucination or delusion can happen also. So usually onset is very important. So in delirium onset is very abrupt, while in dementia it's like insidious and progressive. If you ask like family will say yes, yes, sometimes in sundowning, particularly in evening time, he talks irrelevant, sometimes he sees things which are not there. So history is also important. And for delirium, it's hours to days, while in dementia, it's months to years already. In DCM-10 diagnosis for dementia, at least symptoms should last for more than 6 months. Now, attention, if you see in delirium, there is a reduced ability to focus attention or shift attention at presentation, while in dementia, attention is not that reduced except in advanced cases where it is very difficult sometimes to judge. And consciousness is usually intact in dementia. Patient will be conscious alert, but in delirium, it's a fluctuating. Sometimes he become alert, sometimes he becomes drowsy, like that. And speech usually in dementia is coherent. It may be associated with aphasia, but whatever he is telling is coherent talk, while in delirium, it's incoherent talk and disorganized. So these are the other in chart you can see like differential diagnosis like metabolic encephalopathy, vascular dementia, PD dementia, frontotemporal dementia, where there is a you get classical disinhibition and aphasia. So apart from that, sometimes episodic memory deficit is also there in initial phase of Alzheimer's disease. The most common cause accounting for vast majority of causes are Alzheimer's, followed by vascular dementia. Sometimes we get mixed dementia also. Apart from that, Lewy body dementia and frontotemporal dementia are present, but they are much less common compared to Alzheimer's disease and vascular dementia. So this is the a diagnosis and assessment of a patient with a suspected Alzheimer's disease. We are talking more about Alzheimer's because this is the more commonly we get. So first is the like a pre-diagnostic test, like identify risk for neurocognitive disorder, ask whether there was a family history of Alzheimer's or not. So take medical history, do the cognitive test like MMSE. You can do MOCA also, and daily functioning. Then how the whether patient has completely impaired activities of daily life, or there is a like a, in parts it's impaired, like his calculation is impaired but geographical disorientation is okay, so like that. So you have to find out in which domain he's performing poor, like whether it is like in judgment planning, whether it is in calculation, whether there is his food related habit, or whether it is in geographical orientation, like that. And definitely you have to at the same time you have to rule out, because sometimes it might happen that patient has Alzheimer's disease, but at the same time he had some disease, part which can be corrected, like Alzheimer's disease can have concomitant vitamin B12 deficiency, can have concomitant hypothyroidism, or other correctable causes. So when you get a dementia which is clearly diagnosed with Alzheimer, previously diagnosed as Alzheimer's disease, still you have to rule out whether there is a concomitant condition. At least you can treat that condition and patient can improve a bit. So the most recent diagnostic guideline from the National Institute on Aging and Alzheimer's Association defines three stages of Alzheimer's disease. One is preclinical stage, like neuropathological changes occur. Here, there is no overt symptoms. Now, phase of mild cognitive impairment, symptoms become apparent. ADL are what, but at this time are relatively preserved, and patient does not have dementia. And in dementia phase, activities of daily life impaired. So mostly what we get from like our patient when they reach to dementia phase, then only they come to us, sometimes even after many years after that, because many a times like they consider it as like aging process. So usually most of the time when a patient comes to us with the features of dementia, pathology starts years before the diagnosis of dementia. So that is the problem with the dementia, because whenever we get the patient, it's already very late. So we never get patient in preclinical phase because at that time there is no symptom. So that's why now research is going on, like how we can identify uh, like dementia in preclinical phase where we can do something more. So Here, there may be some preclinical neurological changes in the form of CSF or amyloid imaging biomarkers. So, biomarker can be used to define Alzheimer's disease as the probable underlying cause, and the accuracy of diagnosis is enhanced by integration of biomarkers. So, this is normal brain, and this is, you can see how the Alzheimer's brain looks. And usual, apart from ruling out other causes, commonest what we imaging is we do is MRI brain. And MRI, apart from MRI brain, if in a mild cognitive phase, you sometimes may get normal MRI. And sometimes even if you don't tell, like particularly dementia protocol, they don't see lobe wise affection. So sometimes if you do just a plain and simple MRI, then you will get normal. So you have to be very specific and tell that at least when they check differentiation of different lobes uh, when they do the reporting. So we do a lot of MRIs where they report it as a normal, but if you look minutely, then there is already atrophy started. So what we get usually in dementia, in MRI imaging, you will get only atrophy, that nothing. So sometimes they write is a diffuse cortical atrophy or mild cortical atrophy, and that is actually not a very acceptable term. You can call it as a vague kind of, but this is how like most of radiologists still report. uh, Apart from that, if what will you do if you do MRI and just get it at normal? So, and if a patient is in a mild cognitive phase, there's only so you can do further some diagnostic test if family agrees. What we can do, you can see CS, you can do CSF and check for tau and amyloid. And apart from that, you can do a PET CT brain or a SPECT of brain. Sometimes, particularly PET CT, like it can show hypometabolism in certain area, which can give you an idea like, yes, this patient has like a dementia. So sometimes we do, but yes, mostly these are actually costly tests and sometimes are not feasible also. So now we will discuss about what are the treatment goals. So, target for treatment is improve the cognitive function, amelioration of associated behavior and psychological symptoms, improvement of or stabilization of global functioning and daily activities of life. So, preferably plan the treatment after comprehensive evaluation, and clear understanding of the treatment targets and proper monitoring of outcomes following treatment are important. So, clearly tell a family that whatever drug you are giving, it will not change the pathology. So what we are doing in dementia, we are improving symptoms. Sometimes it may be behavior symptoms. There may be mild improvement in cognitive function, but again, that may not last for a long time because this is an ongoing process and that patient will gradually go down further. So in coming years, what will happen that he will forget more. So when you are treating dementia, you have to tell family, so we are not treating pathology, we are probably with drugs trying to improve his symptoms, improving his daily activities of life, we are improving his behavioral and psychological symptoms, and probably are a little bit delaying the symptom onset. But ultimately patient will go into advanced stage, and at that time he will not recognize anybody, so and he will be completely dependent on family members for his daily routine activities. So when you are treating a dementia patient, you should be very clear what you are treating. So there are many supplement drugs available, but still these are all supplements and they have not yet like clear cut guidelines to use them as a treatment. You can use them as a supplement. Now, what are the pharmacological intervention? So pharmacological intervention, you can see in mild to moderate Alzheimer's disease, you can use rivastigmine, you can use donepezil, or you can use galantamine, and gradually you can reevaluate the patient and can increase the dose also. On if patient develops adverse events with one drug, then you can always switch to other cholinesterase inhibitors. So Sometimes if a patient can tolerate, you can go with higher dose also. So in mild to moderate, you have to start with a low dose. Now if a patient has moderate to severe, then what you have to do, you have to use a higher dose of cholinesterase inhibitor. And at this time, apart from cholinesterase inhibitor, you can also use memantine. So in mild to moderate Alzheimer's disease, we only use plain and simple like either donepezil, rivastigmine. But if it is like moderate to severe, then you can add memantine, and you have to titrate probably every 6 month interval. And if a patient has absent advances to loss of all cognitive and functional uh, abilities, consider treating whatever symptoms he had at that time. I think whatever drug you give, it's not gonna work. So even at that time, you have to treat mostly behavioral and psychological symptoms. Even if you sometimes in later stage, we have seen that patient might have later on difficulty in tolerating the drugs which he used to tolerate earlier. This is the another like pharmacological management for non-Alzheimer's disease dementia. Like for mild to more moderate Parkinson disease dementia, cholinesterase inhibitor; severe PDD, cholinesterase inhibitor; dementia with Lewy bodies. Here you have to remember that in dementia with Lewy bodies, you have to avoid memantine. What vascular dementia also, like you have the same drug. So most like dementia, if it is a degenerative, drugs are more or less same. So
That's
this
good.
is again this is the mechanism of action, how it works. I'm not going into detail. So now that is also important, like which medicine you have to avoid that may cause cognitive impairment, particularly in elderly way, because at that time they get a lot of drug which may cause cognitive impairment. So here is a like anticholinergic cognitive burden scale. So the anticholinergic cognitive burden scale, if the sum of the score is 3 or more, consider medication with lower anticholinergic cognitive burden score. And sometimes if you use high burden drugs, it can aggravate the dementia system. It can further lead to behavioral side effects, hallucination and delusion. And you can see here with amitriptyline, which are very commonly used drug, amitriptyline, and even like you can see, which we frequently use, trihexyphenidyl. So you have to be careful while using this drug, particularly in elderly. If you see the symptoms of like hallucination, delusion, and more behavioral problem, then you have to avoid this high anticholinergic cognitive burden pills. So particularly among these important is like what you can see here is like amitriptyline and trihexyphenidyl. Apart from that, like there are some other drugs also, uh, but these two drugs I am talking because these are we use very frequently. Similarly, like paroxetine is also an important drug. Procyclidine sometimes we use, which can lead to cognitive impairment. So you have to be careful about using this drug in dementia patient. These are the non-pharmacological intervention like lifestyle, good food like fish, vegetables, legumes, fruits, cereals. Instruct caregiver to facilitate social interaction and remain network. So they have to talk. If they are more and more isolated, they will their symptoms will aggravate further. Instruct so caregiver training is also important. So instruct caregiver to include orientation information, like every day they have to made aware that what is the date, what is the year, because they are not aware of the surroundings, so they forget everything. So orientation therapy is another important part. Encourage maintenance of good sleep. So sleep deprivation sometimes can lead to further aggravation of symptoms. Encourage regular physical activity, exercise, and recreational activities. Music therapy sometimes may help. Whatever music they like, you can give them. So sometimes it improves language functioning and symptoms. So there are other lifestyle intervention also. I'm not going into detail. Now I'm moving to a delirium. So Delirium, like what is delirium? So actually delirium is derived from the Latin verb delirio, means to be crazy. So Diagnostic and Statistical Manual of Mental Disorder, means DSM-4, defines delirium as follows, like a disturbance of consciousness, attention, cognition, and perception. And it is a common psychiatric syndrome which commonly heralds an increase in morbidity and mortality. Definitely, if a patient who is admitted in hospital with some other problem develops this delirium, then the increase in morbidity and mortality increases. So it has been seen that in general ward up to 20%, and in ICU even up to like 30 to 40% of the patient can develop this delirium. And among elderly, like almost 30% elderly while during admission in some phase develop this symptoms of delirium. Sometimes it is easily manageable and short lasting, sometimes it is prolonged. So patients with delirium remain in the hospital longer and more commonly discharged to long-term home care facilities. Behavioral manifestation of delirium may interfere with treatment compliance and offer precedents for psychiatric consultation. So the core symptoms of delirium include a disturbance of consciousness that is accompanied by a change in cognition. It develops over a short period of time, usually hours to days, tends to fluctuate during the course of the day, and the degree of difficulty in this area may be greater or less over the course of the day. But overall, delirium represents a sudden and significant decline from the previous level of functioning. So usually it's temporary, reversible, and does not reflect a persistent psychotic disorder because it may have multiple causes. So if sometimes if you treat the cause, it improves suddenly. So you can call it with multiple names like acute confusional state, intensive care unit psychosis, what psychosis, and acute brain failure, sometimes toxic metabolic state, you can call it central nervous system toxicity, sundowning. Organic brain syndrome is another term. So it can be defined as a like multiple synonyms with multiple names. Like organic brain syndrome is also very commonly used term for this. So pathophysiology still is not well understood, and because of the heterogeneity of the etiologies and the presentation of delirium, there may not be single mechanism. So probably there are multiple factors uh, which can be involved in pathophysiology of delirium. So if you see the proposed theory, like it may be because of the neurochemical abnormality, like it may be like NMDA inhibition or GABAergic inhibition. It may be because of the alteration in metabolism. It may be involved with cytokines and acute phase reactants and change in the permeability of the blood-brain barrier. So these systems are not mutually exclusive and may have considerable interaction. So this is the very good picture which shows like there are several neurochemicals involved in delirium pathophysiology. Like if a medication like a stroke medication, sometimes dopamine activation can lead to delirium. Sometimes medication like alcohol withdrawal, which leads to cholinergic activation, can lead to delirium. Even similarly, like sometimes sudden like medication, medical illness, or surgical illness, which lead to sudden cholinergic inhibition, which can also lead to delirium. Similarly, GABA activation or reduced GABA activity, like benzodiazepine alcohol withdrawal, benzodiazepine and hepatic failure. Sometimes due to hepatic failure, glutamate activation. Sometimes cortisol excess like glucocorticoids, Cushing syndromes, surgery, stroke can lead. So you can see like some with serotonin deficiency, serotonin activation. So all this pathophysiological neurochemical parameters are actually involved. So it's not like that the single cause you can pinpoint. So feature are like usually you can see we already discussed a bit, like fluctuating level of consciousness, attention impairment, disorientation, memory impairment, sleep disturbance, agitation, and emotional lability. So these are like common feature. So we divide this delirium again into three major types. One is the like hyperactive patient. Here are agitated, disoriented, and delusional. Sometimes they may experience hallucination also, and this presentation can be confused with that of schizophrenia also, or agitated dementia, or a psychiatric disorder. So in hyperactive delirium, mostly limb movements are there. They, like, you have seen patients like they want to get down from the bed, you have to restrain. Many times nurses restrain the patient, they sometimes try to get up. So this we call, because of hyperactive, where motor activity is hyper, so means that they have lot of motor activities. And sometimes in hyperactive delirium, their motor power seems to be more compared in normal condition. Like, you might feel that their motor power, sometimes they can lift things with hands which usually they cannot, that in particularly in hyperactive delirium. And that's like, because of this hyperactive delirium, many a times in villages or in suburban, they think like some godly thing is happening, particularly because there is a hyperactive delirium. So it has been seen that in hyperactive delirium, muscle power can increase up to 3 to 5 times. So that is a very important thing, like, because of this symptom, sometimes they can do things which they in normal condition they cannot. Now another important is hypoactive delirium, which is usual many a times underdiagnosed, and sometimes misdiagnosis is also there. Because what happens, like in hypoactive delirium, they remain lethargic, confused, bit disoriented and apathetic. They are not responding to sometimes command. They are looking in a vague condition. So delirium in this condition, because of this symptom, sometimes go unrecognized, because many a times we think like probably patient has depression or patient has dementia, that's why they are not talking. So history here is also very important, like whether they have any past history of dementia or not, whether there is any factors contributing to depression or not. And mixed is like when they fluctuate between hyperactive and hypoactive subtypes. Now, this is the diagnostic criteria. So, disturbance of consciousness means reduced clarity of awareness about the environment with reduced ability to focus, sustain, or shift their attention from one place to another place. Another important diagnostic criteria is a change in cognition. It may be memory deficit, means they cannot remember what happened last night. Sometimes they are disoriented. When you ask them whether you are in hospital, they can tell you some other place. Sometimes they tell you a place which is like not even possible to go. Sometimes they have like language disturbance. They cannot even name the common things clearly. And they have sometimes development of a perceptual disturbance, means a doctor goes to them and some they identify them as some other person, whether it may be related to their relative or sometimes close working staff. So it's I think a change in like perception is quite common. We see a lot of delirium patient when they sometimes identify doctors or nursing staff as an another person. Now, another important is the disturbance develops over a short period of time. We already discussed about how to differentiate delirium and dementia. So here disturbance develops over a short period of time, usually hours to days, and tends to fluctuate during the course of the day. So it may happen that in the night they were delirious, but again in the morning they are talking relevant, and again in the night they become delirious. So evidence from the history, physical examination, and laboratory finding indicate that the disturbance is caused by direct physiological consequences or general medical condition. So now coming to management of delirium. So diagnosis of delirium is made clinically through history, examination, mental state examination, serial observation of patient. Now onset, feature, baseline history, whether there is have a underlying dementia or not, whether they have like past neurological condition like stroke, seizures. Sometimes like I forgot to tell you, hyperactive delirium sometimes are underdiagnosed, and we sometimes miss like ongoing seizure activity or non-convulsive status epilepticus also. So particularly with a hypoactive delirium, like you should always think of doing EEG. So now again coming to management, so you have to find out like risk factors for delirium, general medical illnesses. General examination is same because delirium may be because of the sepsis. We see quite commonly it may be because of the increased urea, it may be because of the hypocalcemia or hypoglycemia or hyperglycemia. So when you are treating delirium, managing delirium, you have to rule out all these causes which can lead to delirium. Any infection, metabolic abnormality, or old history of dementia, whether there is a stroke, or so anything can lead to delirium. So you have to complete with a general examination like respiratory. We have to check whether there is a like heart rate is like fast or not, or there is tachycardia or tachypnea, whether there is a like Krebs or not, because many a times pneumonia patients like or lower respiratory tract infection patient become very delirious. UTI, we have seen like patient present with a confusional state or delirious state. They have no fever, no symptoms of like dysuria, no burning sensation, no smell, just only a confusional state. So UTI, similarly in elderly, like hypoxia or lower respiratory tract infection, sometimes can lead to delirium. So funduscopy in CNS, you have to see fundus to rule out papilledema, because sometimes cerebral venous sinus thrombosis also can lead to delirium, but it is mostly associated with headache and vomiting also. So this is the common mini mental state examination and memorial delirium assessment scale, and another is like a confusional assessment method like SCAM. So sometimes these screening tools are available, but sometimes it's difficult to do because patient is not cooperative. So mostly we have to rely on the clinical feature. So these are the full investigation, like what you have to do. CBC, you have to do CXR, like you have to do electrolytes, LFTs, ammonia, and we do it for quite frequently. Nutritional, you have to consider particularly in alcoholic patient whether there was like thiamine deficiency or vitamin B12 deficiency. Toxicology screening and drug levels are also very important. You have to check with like oxygen levels, CNS imaging, CT always you have to consider always, an EEG like particularly in hypoactive delirium, EEG should be done in almost every patient. So lumbar puncture, if there is a evidence for increased ICP or if you see the meningeal features, then you can consider lumbar puncture also. And definitely in delirium, treatment should be focused on identifying the cause and then treating it. There are three major goals. One is to find and reverse the contributing factors of delirium. Second is to ensure the patient's safety while educating patients, family, and staff. Because sometimes it's difficult when like patient family member come and they see restrained patients, they sometimes feel offended. We have quite commonly see. So you have to tell a family member that we have to restrain them because they are otherwise they can do self harm. So to protect that, we have to restrain them sometimes. And definitely third is the symptomatic treatment of behavioral disturbance associated with delirium. So again, management can be divided into pharmacological and non pharmacological. Now pharmacological is like, apart from treating underlying medical condition, you have to consider some antipsychotics. So antipsychotics may be considered if psychosis, severely disorganized thought process, or extremely physical and verbal agitation places the patient or others at risk or harm. Sometimes they like try to get down, or sometimes they have like abusive language. Sometimes they are throwing things and holding things very tightly where they can injure themselves. Sometimes they are like pulling their catheter. Sometimes they are trying to remove rice tube like that. So usually here what we do, we use low dose high potency antipsychotic agents, which are most frequently studied again the treatment of delirium. So they may benefit an agitated patient by following allowing completion of diagnostic test. At least when if patient is not quiet, you cannot do any test also. That is another important thing. So you have to uh, keep them quiet to do the test. So usually what we use haloperidol, and which it has the longest track record in delirium management and may be given orally, intramuscularly, IV. And I think this is the most common drug we used frequently in delirium, except like where you have to be very cautious. If a patient has a Parkinson's disease, then you have to be very careful while using this drug because it can lead to extrapyramidal syndrome also. Or if a patient has a past history of extrapyramidal syndrome, you have to avoid. Apart from this non-pharmacological management, like you have to communicate clearly, clear verbal reminders what you are doing. You have to show them the clock, like what is the time. You have to show them the calendar, familiar objects from patient's home, consistency in staff, because everyday staff changes. That is the common thing what happens in hospitals, and sometimes they cannot identify, so that's they become more delirious. So involve family for feeling of, sometimes we involve families who can tell them and orient them. So remove unnecessary objects, avoid using medical jargon like in patient's presence which may induce paranoia, adequate lighting, avoid noise, identify and correct sensory impairment, encourage self-care, maintain activity levels. So ambulatory patients should walk 3 times a day. So they have to, if they are agitated, sometimes they want to walk like that. So sometimes definitely you have to ensure safety and then can do these things. Family education. So here I stop and like we are open for discussion. If any question.
Sir, excuse me, sir.
Hmm.
I'm Dr. Rijit from Tata Medical Center,
Hmm.
intensive care. Just my question is that in this dementia phase, whenever there is pre-existing history of taking any medicines for psychiatric illness that's leading to dementia
Yes,
in
yes,
any
yeah. So
later
that is
development.
very common. Like particularly as you have seen that's a drug level, the score. So
Mm.
any drug which is included in that group, particularly if a patient is delirium, you
Mm.
have to avoid. But again, remember that you cannot do the sudden withdrawal also. So if
I'm
a
asking
patient
about
is
the
drowsy,
dementia. I'm asking about I'm
so
asking about the dementia. That in
hmm,
that case, sir,
yes.
what drug would be more preferable? Is there any pre-existing psychiatric illness that causing the dementia, or any
Hmm.
long-term use of any antipsychotic causing dementia in early years of life? That
So
you
here you
told
can
me that
prefer a rivastigmin
rivastigmine
and
and
yes. So I understand, like in a psychiatric disorder, if a patient has dementia, you want to know like which drug we should prefer. You can here prefer a donepezil or rivastigmin, and later on, if advanced disease, if they can tolerate, you can use memantine. But again, memantine sometimes aggravate the symptom also. So sometimes even we have seen that the same
okay, sir.
drug patient cannot tolerate. So tolerability is another issue. It's not always like you cannot give a drug. You can give all the three drugs like donepezil, rivastigmin, but sometimes they prefer one drug over another. So sometimes they have side effect with donepezil. They cannot tolerate even lower dose, and they can tolerate rivastigmin. Similarly, also in psychiatric disorder, if you have to treat dementia first, you have to check like whether there is any drug which can cause memory impairment, antipsychotic drug. So at that time, you have to tell psychiatrists to avoid that drug which can cause dementia or aggravate dementia. After that, you can use either this donepezil or this rivastigmin with low dose and gradually. So particularly in such patient, usually we start with a very low dose and gradually over the weeks we build up the dose, because it you never know, sometimes they might face problem with one drug and they might tolerate another drug.
Okay,
But
sir.
drug
Sir,
mostly are
my,
these three.
my two questions are there. That what all type of atypical or typical antipsychotics mostly causing this type of
Hmm.
dementia, very commonest. And in case of this treatment of dementia, whenever we are using the rivastigmine or this donepezil, anticholinergic esterase inhibitor, in that case, is there any side effects whenever we are
Yes.
acutely using the anticholinergic esterase
So
inhibitor?
some, yes. So
How
this drug,
patient behaves in that time?
yeah, so particularly as I said, like whatever drug you can choose, but you have to be very careful about the dose. You cannot use the higher dose in such patients. You have to, you can either, because it's very difficult to predict which actually group they will prefer. So they can probably can tolerate one drug and cannot tolerate another drug. And another important thing is like particularly like in, for example, in PD dementia, Parkinson's disease dementia, olanzapine, you know, is a very common drug we use very frequently, but usually in Parkinson's disease dementia it can aggravate the symptoms, so you have to switch back to clozapine, like
Yeah.
that. So these are the something like particularly in some certain conditions, like particularly in Lewy body dementia. So you in Lewy body dementia, when there is a like you, what happens in Lewy body dementia, like you can see marked difference in morning and evening time. Morning they are very quiet, alarmed, and like talking, and in evening time they become very agitated. They show features of delirium. Here you have to completely avoid memantine. So, if, similarly, in a psychiatric disorder where you can see hyperactive behavior, memantamine can further aggravate the symptoms. So,
Okay.
that's the thing, like you have to judge. Like if the psychiatric disorder but depression is more common, then you can use like that.
Does the lithium lamotrigine in case of depressive, manic depressive
Yes,
psychosis?
so
Mm.
usually lithium in elderly, particularly apart from this dementia, causing dementia, worsening dementia, they have many other side effects also. So when you are using lithium, you have to, it's used in very severe actually cases only. Lithium we are currently not using very frequently. There are newer antipsychotics which have much less side effect compared to lithium. But yes, sometimes you know, or sometimes some patients like work better with some drug. So if they are already taking lithium for a certain period and they are well, particularly in bipolar affective disorder, like if they are well tolerated, then you have to continue with the lowest possible dose and you have to monitor lithium level at very regular interval.
Okay, sir. Thank you, sir.
Is there any question?
Hello.
Aspirants,
Yes.
if you have any question, please ask.
Hello.
Yes, yes.
Yes, sir. Myself, Dr. Mahesh. I am the family medicine resident from
Mm-hmm.
Guwahati. I want to
Mm-hmm.
ask one thing, sir, as I am like seeing multiple pediatrics patients also along with medicine. I want to ask one thing that like how delirium is kind of different in children's than in adults because
Yes.
the presentation is not similar, sir.
Yes. In pediatric diagnostics, the delirium is quite different because they so abrupt behavior sometimes. So how particularly we identify delirium? Because in children, you know, throwing tantrum is quite common. So, if a child like who is going treatment under a hospital, particularly if he has an infection, whether it is a viral, and sometimes if it shows abrupt behavior, wanting something which he usually doesn't like, or sometimes if their food habit suddenly changes, and if sometimes he uses language which is actually he is not very versed with, then you have to consider that. Probably he is developing feature of delirium, but again in children mostly delirium are caused by some systemic illness. Like in elderly, what happens, like there are multiple factors like deficiency, thyroid, vitamin B12, or sometimes underlying dementia, degenerative, but stroke. But usually in pediatric group, mostly delirious behavior when we see is mostly due to either infection or metabolic disturbance. So that's why you have to treat the actually a condition. Delirium will automatically go.
Thank you. Thank you so much, sir.
Excuse me, another question, sir.
Yes, yes.
Sir, in elderly, in patients coming with delirious state
Hmm.
or any triggering factor infection, whatever, in
Hmm.
ICU patients, the patients develop delirium, and as well as patients having past history of Alzheimer's in case of some
Hmm.
elderly patients.
Hmm.
So how can we differentiate in such situations the patients behaving anxious, agitated, restless, these patients pulling out everything? in that case, how can we recognize, is it the
So
role of Alzheimer's or delirium?
no, again, remember that in Alzheimer's, what happened mostly, what we see is delirium superimposed on dementia. So these patients are like highly prone to develop delirium. So, like for example, like if a patient has a dementia, like he was forgetting things and suddenly he becomes delirious in the morning. So, most common diagnosis is delirium superimposed on dementia, particularly in Alzheimer's disease. In Lewy body dementia, like itself, dementia sometimes can cause a delirium in particularly evening time. So, this doesn't change much. So sometimes, as I said, like it is difficult to differentiate whether it is only delirium superimposed on dementia, or it's like pure delirium. So in such cases where it's different difficult to differentiate, you have to treat delirium first, and at the then once patient settled out, you continue treatment for dementia. But
Okay,
most commonly, what we see in dementia and Alzheimer's patient, if he develops delirium, its most common diagnosis delirium superimposed on dementia.
thank you, sir.
Good night, everybody. Thank you for the interaction.
Thank you, sir. It was a
Okay.
nice session. Thank you.